Evening, everyone. My name is Tom Kelly. I'm the Director of Clinical Services here at Westside Regional Center, and I'd like to introduce our presentation and some of our fabulous panel that we have here to present this evening. As you can see, the presentation tonight is on how to navigate the mental health system, accessing services for a child with co-occurring needs. We're doing this out of our disparity money from the state to be able to present on a number of topics involving transition age youth, both looking at younger children transitioning out of early start services, as well as those transitioning from high school into adult services. This is a very important topic, and it's very timely, especially in COVID, where the disparity in our country, disparity in our community is becoming more magnified. And what we're seeing is more difficulties for individuals being able to access and navigate healthcare, mental health, school district, a number of different services. And this is particularly apparent in disenfranchised, lower income, and in people with color. So that there's a great need to really look at how we navigate these services, especially now. Because I think mental health is going to be more of a burgeoning need in our system more than ever right now in COVID. So I'd like to introduce a few of our presenters this evening. First, I am happy to welcome Lisa Schuyer. She's a caseworker at the Los Angeles County Department of Mental Health, where she is the department's countywide regional centers liaison coordinator and countywide regional center liaison for birth through school age. For over a decade, Lisa has been advocating for access to mental health services for individuals with intellectual and developmental disabilities. Lisa also has a son with a rare genetic syndrome who was a regional center client. I'd also like to introduce Jacqueline Finch. She is the Service Area 5 Child and Transition Age Youth Navigator, Regional Center Liaison, and School-Based Mental Health Coordinator for the Department of Mental Health. Jackie has worked with the transition age youth population in the juvenile justice system, as well as within the field of community mental health. I'd also like to introduce David O'Neill, who is the director of the IDD services at Sound and Project, and he's also the project instructor for the Center for START Services, the national team. Finally, hello, David, welcome. I'd also like to introduce Kaylee Morgan. She's the Associate Vice President of Regional Center Programs for Exodus Recovery. She's been working with people with intellectual and developmental disabilities who also have behavioral health needs for over 10 years. She is passionate about developing and implementing programs to serve these individuals and for those supporting them as effectively as possible. I'd like to hand it over to, hello, Kaylee. Now I'd like to hand it over to Lisa. Thank you, Lisa.
Thank you, Tom. Okay, so our training goals tonight are to understand the differences and similarities of the behaviors related to mental health and to developmental disabilities, navigating the mental health systems, where can we go, how to request for services, and then available mental health resources. So I think from the family perspective, we start with all these concerns that we have, and we don't know where to go. Is it regional center? Is it health? Is it mental health? So, and I think it should be familiar with the people in the room when we see these and get concerned. And the first thing we should do with our concern is to take care of ourselves first. And it's actually a great exercise for all of us during COVID as well. We call it the belly breath, the belly breathing. So that's why we have Buddha there. And another way we can do it with individuals with developmental or intellectual disabilities is just to take a feather or even a scrap of paper and say, blow this as long as you can. And let's have a competition. Let's see who can do it longer. And doing that helps us actually release hormones that calm us down. So it's really just actually it's kind of very useful when we're betwixt and between. And then the next step is to really take a good look at where we see the challenges happening. Actually, what's happening in the first place? What am I looking at? What do I hear? Where is it happening and when is it happening? It's really important to know these things because we need to figure out if it's a situation or a person, in which case we want to go to the person or take care of the relationship with that person who's making these concerning behaviors, or is it something that's happening across the different areas of the person's life? Because mental health issues affect across everywhere, the way the person sees. So the other things to consider too is the family environment. How does culture affect the behavior? And a classic example is communities where a little child should not be speaking because that's not what you do. You're silent and you listen to the adult. So if there's a delay in speech, for example, it might be culturally appropriate. Or if there are customs, we know about people who came over from Africa I think an entire community came over as a refugee group, and their children had delayed walking. So we were really worried about that. The public health people, it's like, oh no, there's a delay. But because they raised their children carrying them on their backs to do field work, their children were normally learning to walk later than our culture. So these are kind of the things that we need to be aware of as providers of mental health when we're looking at the needs and issues, that we're really being culturally sensitive and aware. In terms of language as well, the words that we use, are they something that is appropriate for the people that we're talking with? Are we speaking apples to apples? And we'll get into that a little bit later because it happens between organizations too and services. And then the caregiving situation, what's going on, the relationships that could be affecting a person's behavior. Also the social environments with our population on the phone now, with the peers, what's going on between them. Is there bullying? Is there support? Is there somebody who's there to be helpful, who might have left for a moment or a long time? Maybe they moved away. What's the community and neighborhood like? We know also, a reason for not wanting to go out could be that the streets are not safe, or the person feels like the street isn't safe, right? Because of what's going on in the neighborhood. And schools now, we know that's really just a wild, wild west out there, and everyone's doing the best they can. And half the challenge is that the rules keep changing. So everyone's trying to stay on top of it and do the best we can, and things fall between cracks and stuff. So we want to make sure that all of those considerations are put into the pot and stirred around. So with respect to today, we're going to look at the developmental system, the mental health system, and we threw in education because we are talking about youth who are transitioning out of school. So there are school services, they're limited, that's why it's a little smaller. And they're also related only to educational goals now. So it's a resource, it's a place of confusion, so we just threw that in. But the focus is going to be about the mental health for the individual. So I think the first thing we need to do is to define what mental health is. And so we start with a definition from a training called Youth Mental Health First Aid, which is what even Michelle Obama is encouraging people to take as a way to learn more about mental health and what to expect and how to help people before it becomes a mental health problem. So a mental health challenge is any disease or condition affecting the brain that influences the way a person thinks, feels, behaves, and or relates to others and to their surroundings. So in the general world, this is the mental health situation. So this is not even with developmental disabilities yet. We have more than 1 in 5 parent in this survey saying they have a child with a mental health or behavioral problem. That's more than 1 in 5. Most of these parents in the survey had concerns, and they did look for treatment, but they waited almost, for half of them waited more than a year to get it. So there's a challenge there. And more than a third of those said they did not understand their mental health coverage. So hopefully today we'll have strategies to help more than a third of those people. And then, the other thing that's really important to remember why we're really focusing on this age range is that 1/2 of all chronic mental illness begins by the age of 14 and 3/4 by the age of 24. And that's the typical population. Tom, you want to?
Yeah, I wanted to add to it. So it's particularly challenging, and we see probably an earlier onset with individuals with developmental disabilities. And so what we're really focused on is preventative care. We know that with prevention, with early intervention, that we're really able to prevent a long-term course of significant intervention and significant challenges. So that this is why we're really emphasizing this. I can't emphasize it enough that earlier is better, and that early intervention really works, and it really affects, the long-term longitudinal outcome of these disorders.
So let's start with defining development. Now let's go next to defining developmental disability. And when I first designed this, I learned that the word mental or physical impairment was used in the language of on the state website. And I showed this to somebody at another regional center, and she said, no, it doesn't say mental. And I said, look it up. And she did, and there it was. I believe they've changed it now, but this is why we have this confusion from way back with our Department of Mental Health saying it's regional centers' problem because they have mental. See, they use the word mental. But in reality, the Department of Mental Health's role has always been and always is and always will be to address the mental illness. So the clarification, which has been fixed on the website newly, is that they're talking about cognitive impairment, not mental illness. So that's the difference between developmental disability and mental health. So on the developmental disability side, we have 1 in 6 children in the United States has a developmental disability. So if we put these together, we learn, we found out from looking for people who counted the numbers, at least a third of the individuals who live in, let me say, state institutions, at least a third of them have a mental illness. And we're pretty sure that it's underdiagnosed because it's very hard for people to tell. So we know that it's really, there are a lot of people out there who could use help before they get to this point. So that's what we're hoping to do today too. So here we go again to sort what we saw in terms of that first dark cloudy space. We're looking at the things that are, the concerns that are developmental milestone related, things where a person needs help with self-help. So putting on clothes, brushing teeth, other stuff like that. Communication, needing help with either receptive or expressive communication are generally in the developmental side. And on the mental health side, if a person starts to hear voices, if they're sad all the time for a really long time, same with anxiety for a really long time, it looks different in the population with IDD because of slower development of the prefrontal cortex, the piece that doesn't develop until typical people are in their mid-20s even. remembering to feel sad or anxious over a long period of time is just not the same as with the rest of us, where we kind of get all stuck in it. They might be able to go off and do something else, you know, oh, look, coffee, I've done that, right? Oh yeah, I forgot, I have, sorry, see, I did it. And then something reminds me back again that I'm sad or anxious. And this is more common in those with IDD. If a person is avoiding specific people, places, or things, we want to double check why. Another example we have of that is a young man who became pretty big in a group home. Whenever a guy would come in to take him to do something for a trip or something, he would get really mad, and he was nonverbal. So and when he was little, he would just do this, but when he was bigger, it was even scarier because he was big. And finally, somebody in the group home said, I think I heard his sister say that he witnessed his dad beat his mother. And this man looked enough like his dad that it triggered his trauma response. So that's the kind of thing that mental health would work on. Safety concerns, suicidal, we really want to be aware of that's our job. We need to work on helping the person not feel like suicide is an option. And the way we see it in the IDD population is often actually running into the streets to be hit by a car. So those are signs of being so sad, in such pain, and so anxious or so depressed that they're willing to try to stop it by harming themselves that way. So we are definitely the people to come for that.
And Lisa, I wanted to interject real quick that one of the difficulties in identifying individuals who have co-occurring disabilities, there's often misattribution that's seen as behavioral, it's seen as primarily, related to the environment or related to a caregiver, and not seen as a mental health condition, which is why it's the incidence of co-occurring disorders is, I think, so underreported. You said 33%, and it's anecdotally, my experience has been it's much higher than that, but it's often not recognized, and we fail to see it, and we see it as something else that it's not, because people see it as part of having an intellectual disability or part of autism, and not recognizing that in fact it is attributed to a mental health condition. So it's one of the problems we have in identifying and making sure we get the right intervention.
Yeah.
Letting speakers know that there's 15 minutes in.
Okay. So let's go back to all the services we should think about. Then the first thing we should think carefully about is the physical health. So, and the challenge is, what are the observed concerns? So one example that I just learned with a team of people, actually from the START services people, who you'll hear from soon, was the fact that a lot of the people who are coming to them for mental health, developmental disability concerns combined, turns out they had constipation. If I'm constipated, I'm grouchy. I don't even realize I'm constipated a lot of times until I get to the point it's like, I'm uncomfortable. And I can't even tell quite where it is until finally I can tell. It's like, oh man. So if I have that trouble myself, you can imagine people who have poor expressive skills being able to voice that. And my way of dealing with it as a college educated person is to be grumpy at my partner. It's like, oh, come on, let's go do the dishes. No, I don't want to get up. I'm not aware of why I'm being so grumpy. So you can again imagine for those who have difficulty with communication. So really we want to rule out all the physical health possibilities, from the most common to let's make sure nothing else is going on, because that's a different direction. We don't want to throw mental health approaches to a physical health problem. So mental health services. We're going to review the different ways that you can get mental health services. I mentioned school mental health, where they are very careful about just the education goals. So it's good for the education goals, but if a person has other needs, like the beginnings of depression or anxiety that are not related, are beyond education goals, the school is unable to help. But we can coordinate with them. So that's a good thing. And it's a resource. The first thing that we're also going to always be asking, everybody is going to be asking regional centers and mental health departments is, do you have private insurance? Because that's what has to be used first, the generic resource or the community resource first. And they provide counseling and psychiatry services. And then we have Medi-Cal. We have managed care, which provides short-term behavioral health. And then when it comes like serious mental illness, they'll kick it up to the county public mental health. So that's the next bullet, where we are funded both through Medi-Cal, and that takes care of severe mental illness and for youth and children who are considered severely emotionally disturbed. And some of you who have had that experience with special ed, that's usually the way that you get those services, not always. And then luckily for us in California, we also have a millionaire's tax called the California Mental Health Services Act, which provides services by project. So don't worry about all the different projects. The most important thing is if you have a concern, to contact us, and we'll talk about who to contact, who will know about all the different programs and projects that could be available depending on the needs of your child. So specialty public mental health, we're going to look at eligibility, and it's the phrase we're looking for is medically necessary. So I mentioned before, you know, how Medi-Cal managed care does short-term stuff. If it's going to be something like a mild depression, you know, if someone has been screened and it's determined mild and not to the level of functional impairment, then it will not be considered medically necessary to go through us, DMH, but definitely through your health plan, through Medi-Cal managed care. Okay, I hope that makes sense. So now, what are we going to do? What system do we go to? Let's look back here. Now we've replaced regional center. We've replaced developmental disabilities with regional center because that's the service provider, and mental health, that's our department. Now we've cleared it up. So we've gone the same things here and the same things there. And so these middle things, what we need to do is we need to pay attention and dig deeper. The attention problems, what's causing the attention problem? Is it distraction? Is it because, you know, there's too much, like a person with autism, if it's too noisy because they can't filter out the sound in a room when they're talking with people, or too visually busy, or you know, what is it that is causing the attention problem? Or is it because they're distracted because they saw someone get shot, and every time they hear a loud noise, they're responding like that might, you know. So that would be a mental health problem. See, do you see how we need to dig in, refusing to follow directions? Do they really understand, or are they doing it because the directions cause them to do something or not want to do something that makes them feel uncomfortable in some manner? So what's that? You know, we have to peel back and back and back. Making and keeping friends. Is it because they need social interaction support through the regional center? Or is it because their behavior from their anxiety and their depression is causing people to push them away? Or maybe, you know, you don't know, cart and horse. Sleep problems, it's the same. What's causing the sleep problems? Is it nightmares? What are the nightmares being caused by? What's going on behind all of that? When they hit, bite, yell, and cry, and in our population, that's communication. So it's not necessarily regional center, it's not necessarily mental health. We really need to, again, figure out why they're using that kind of communication, and get down to the nuts and bolts of it. And the same with being irritable, which means grumpy, right? Or just easily angry or cry, whatever. So here we have a list, and we have it as a handout for you. So please take a look at it. We've highlighted the things that seem more important. And so this will help us go through this a little faster as well. So when you're talking to mental health, you want to use mental health words, just like when you talk to French people, you wanted to use French. And the regional center, when you're talking to the regional center, you want to use their language, which is, so one is, let's say mental health is German and regional center is French. So if you start speaking French to mental health, we're going to say that doesn't sound familiar. You need to go to France. And the same way, the other way. So this is our first our dictionary to talk to each other. So for tantrums and aggressions, if you see that, if you come to us and you say that, we'll say, oh, you have a person with intellectual and developmental disabilities, that belongs to regional center. But if you say emotional outbursts, then we'll start paying more attention and saying, oh, okay, tell me more. And also when you come to us, don't use the word evaluation because we don't understand that word. And when you go to regional centers asking for services, don't use the word assessment because that sounds like a mental health word. So here's some more things. The next page, we know we in the Department of Mental Health need to learn how to recognize service coordinator. We keep on calling service coordinators caseworkers, which is not right, right? And so the same way you are looking to talk to a clinician or therapist with us. Okay. One kind of gobbledygook word that we use is collateral. And in the regional center world, that means circle of support. So that's the magic phrase. So if you hear us say collateral, you can just look over and, oh, circle of support. Okay, that makes sense. And then this whole last page is like, everything is important. So we find generic resource to be a mysterious word. It's like, acetaminophen instead of Tylenol. Is that what you mean? But that's really a key word in regional center services because their job is to find existing services first for the family. And then the other side, we are looking for community resources, and regional center services is a community resource to us. So that's that kind of regional centers use catchment areas, and we use service planning areas or service areas. I'll show you a map later. Regional centers use we already mentioned, we use functional impairment as a level by which we determine whether or not a person is eligible for mental health services. And in regional centers, it's substantial disability. To be eligible, regional center uses the qualifying conditions phrase, and we use meets diagnostic criteria. And then if there's a need for more care, we're looking for the phrase needs a higher level of care, whereas regional centers use additional services and supports or hours. So, where you can find mental health resources again. So now we've kind of like shuffled the deck and spelled it out again. So there are the community mental health resources. See, I'm using my own mental health language. There's private insurance. There's Medi-Cal managed care, which is health. And there's school mental health services. And then there's public mental health, which is us, the county mental health program. And again, we have the federal funding, which has one set of rules, the most common and most often used. And then there are also state funded projects that are less related to financial eligibility. So anyway, so coming to us now, what not to say. The best thing always is not to say, my child has autism when you call us, because you're telling them information, one, that they don't know for sure, and it confuses us. It's like, you're coming to us with autism, and that's not at all what you mean when you say that. You're trying to set the ground for, and be prepared for the need that I'm not to say. So just best not to even say, just say, I'm really concerned because my child's not sleeping. He started to kick and stuff, which he didn't do before. See, that's another thing about mental health. We are looking for changes in behavior. Regional centers support the development of behavior, typical behavior, And mental health is looking at changes in behavior because that's an indication of something going on in the head, with the brain, in terms of thinking. And so what you need to say is, I'm seeing concerns, I'm seeing new behavior. And then when to say it, as Tom said, and I will echo it, and so does the slide, never too early. If you are just slightly concerned, just ask somebody and make sure that that person is somebody that you feel confident, who's going to, be honest too, because we also know, we've been to the pediatrician, I'm sure, and the pediatrician will say, oh, your child's not hitting the milestones, but it's sort of, there's time. Well, with mental health, particularly among this age, as Tom said, there is time, but the time, it's like that. So let's just make sure. So now.
Yeah, and I'll add to that, just that is a common, in multiple settings, we hear time and time again, let's just take a wait and see approach. And it's not a good approach. And I don't know where that came from. So pediatricians not referring to early start early enough. And the reality is that we can do a very comprehensive early start assessment. And why not see? I mean, maybe they wouldn't qualify, but you still get a valuable assessment. But you see behavioral changes, you see things that are kind of not normal for you, and you're not sure what to make of it. Why not have it assessed and just take a look and see what's happening? And the same thing also with academic challenges. A lot of times teachers will wait, and then what ends up happening is it really impacts the child longer term. Whereas if they would have gotten earlier intervention, it would have really been able to help to catch them up earlier. So these are all things where that wait see approach, not the best way to go.
No, and I think
30 minutes.
a lot of times the concern is stigma that the medical field might have on behalf of the family, which is also not should not be, but they're anyway.
Or they don't, or the stigma is I don't want to concern you.
Right. Yes, exactly.
I don't want to concern you about your concern. So, and so.
Mm-hmm. So we developed this script to help approach mental health providers. So the first half here at the top box is to collect all the information from where we can. So that's all in one page, and it's really handy, is then we can use it to talk with each other and share, and then we're all on the same page. Look, this is what we said, we agreed. So, if you have a DMH clinic, the regional center, information, school information, collect all that. And then what to say. The first thing is, I have an individual who is requesting mental health services. So right there, we're going to be really clear. We're asking for mental health services. And then in one of the three categories, it's really handy, that checkbox, those three check boxes: therapy, medication management, and or case management, all three maybe. And then the next box, due to decompensation or deterioration from typical baseline in the following areas. So now we're starting to use German gobbledygook. Or you can say, with the new concerning symptoms or behaviors in the following areas. And then you can use the checkbox again, at home or school or community or all, interpersonal relationships, religious, spiritual settings, other, you can write it in, track it. And then this is where I had mentioned before, where we want to know when if this is a change in behavior. So when did it start? And, for how many weeks? How often has it been happening in that time frame? Then the second half of this is, so the presenting problems include, and so prompting questions are, what are the issues? What's going on? Why do you think they need mental health services? What are the biggest concerns? And was there any prior history? If there's none, say none. So examples are grief and loss due to several deaths. Family is concerned he may be depressed. Calling regional centers, crisis response project due to hitting self, face and shouting. Client reports hearing voices. Client experienced or saw someone get violent in the group home. Going back to the grief and loss. So I love this story. I'll tell it quickly. One regional center had a young man with Down syndrome who was living in a group home, doing very well. His dad would visit him and everything. And his dad died which was very sad, but everything seemed okay. But a year later, he started getting more and more upset, and he started to get more and more violent until finally they had to move him all the way down to the level 14, the most lockdown living situation. And it was really tough because it's like, what happened? He was doing so well. And the people, fortunately, at that facility noticed that he had grief. He was grieving his father's death, but it took him a year to process it. So they gave him mental health services for his grief, and he was able to move back to his original housing situation. So that's the kind of thing that we have to pay attention to, that the responses might be longer too, to anxiety and depression. And the therapies are effective. So, okay. Okay, the box 3 talks about the symptoms. So there are some examples in there. Box 4 is key because this is where the long time confusion we've had internally. Please make note that the individual has an intellectual developmental disability, which would be secondary diagnosis. The IDD is not the primary focus of clinical attention. So hopefully that'll get through, that we're not asking the mental health provider to deal with a developmental disability or intellectual disability. And so then the last one is to document the first appointment. So that's good. So we talked about this. This is a duplicate. Oh, okay. Yes. So going back more to our county mental health, we have specialty mental health, I mentioned already, and the EPSDT, which is for the severely emotionally disturbed. We also provide crisis counseling, and especially like COVID, we are providing crisis counseling for anybody who needs it. And we also have walk-in clinics where we will not turn people away based on their insurance. We'll do a triage, is what we call it. And the state funded, I mentioned that there are, not only are there projects through the Mental Health Services Act, but also there's funding for undocumented individuals if so needed. So, okay. Now we're going down in need of service. We go from the top, which is the most need, hospitals and facility-based care, which is generally run by the state, but I guess, and we pay for the too. Okay, so there we go. So we have specialty programs through MHSA. We have emergency outreach and triage. We have outpatient, that's the most common, through Medi-Cal. And then we have wellness programs. So that's the great thing right now, is we're working really hard at being more open and available on a regular basis. And you'll hear more about that too. So most important for now is our 800 number now has 3 options. So you can push the option number 1 for access to mental health referrals or a crisis situation. Option number 2 is for emotional support. You just want to talk to somebody right away. It's not that you have to go to a hospital because somebody is so upset, but this will help you. And number 3 is for veterans and family members. Here's our website. And again, and if you are looking for a provider near you, go to that last one and type in your address, and then up will pop a map with different providers, and you can start calling them. That's a way to get mental health services. This is the way it works. So you call, and you reach either our access number where you need triage or triage, or you call a clinician, a clinic. And so they'll decide based on what you say if the need is an emergency. And if so, then the next 2 layers are adjusted. But otherwise, if it's not an emergency, then there will be 10 business days before you'll get a clinical an appointment for an assessment, and 15 business days for a doctor's appointment for medical. So the assessments will include the financial, which is, are you a Medi-Cal? You have Medi-Cal, I should say. The clinical need, and then the medical need. And then there will be an appointment for treatment. So if there's a problem, this page is very busy. Be sure to keep it close to you, what to do if there is a problem, and what a problem is, like what you have the right to do as well. So this is from our patients' rights webpage, and you can call them as well. Right now, I think with COVID, your best bet is first to go to the webpage. And so the forms are in many languages, so that's also handy. So going back to the way we provide services, here's a map of all our service areas. And so you folks, and there's Jackie. So the majority of West Side Regional Center is in service area 5. So I'm going to introduce you to Jackie.
Hi, thank you, Lisa. So yeah, like Lisa mentioned, the majority is in service area 5, and for school-based mental health, every school district has a slightly different process. But basically, if a teacher or school counselor notices that your child's behavior is changing or having any difficulties in school, they're concerned that there might be a mental health issue going on, they should talk to you about completing a mental health referral. But especially now with Zoom classes, the teachers may not be picking up on these concerns. So you can always advocate to the teacher or school principal about having them fill out a mental health referral. Like I said, usually you'd go through the school principal, but LEOSD has a hotline that you can call to request mental health services, or there might be a school counselor that you can also talk to. Next slide. Okay, so if you are noticing that your child's mental health symptoms are mostly at home, and they're not necessarily affecting their school performance or behavior, this is a list of mental health providers in the area that specifically treat transitional aged youth that you can always call directly and ask for them to evaluate your child. If they don't have openings, they should refer you to an agency that does. And again, like Lisa went over the Medi-Cal, it's for whether you have Medi-Cal or if you're uninsured. Okay, and then there's a lot of, this is an exhaustive list, but there's a lot of community resources in the area that can support your child's mental health goals. So some of the things that might be affecting their mental health is grief, any physical issues going on, not having peers in the LGBTQ plus community, and then also finding meaningful work. So those first 4 resources are just some of the things that can help support your child's overall mental health. And then also lastly, we have the National Alliance on Mental Illness, and that's where you can find support for yourself for coping with a family member who has a mental illness. So they provide education, advocacy, and support groups to the family members of people with mental illness. Okay. And then this is a list of crisis resources. So it's really good to have on hand. Like Lisa went over, our access hotline, that will direct you if there's a psychiatric emergency that your child is going through, that'll direct you to our psychiatric mobile response team, and they can go out and respond and evaluate whether your child needs to be put on a hold. And also, if your child is more comfortable with texting, there's a crisis text line that they can use as well. And then lastly, so it's a lot of information. It's maybe tricky navigating the mental health system. So every service area has their own navigator to help family members and clients. And so like Lisa said, I'm the navigator for service area 5, which includes all of West LA. But then Westside Regional Center does cover a little bit of service area 6, which is South LA, and then service area 8, which is South Bay. So we have a navigator in each of those areas, and you can feel free to call any one of us. If you call the wrong service area, then don't worry, we'll direct you to the right person. But we're here basically to help if you have any difficulty finding mental health resources, or if you're getting pushback when you're calling any of these clinics and they're saying, no, go back to regional center, we can help advocate for you.
All right.
All right, Jackie, thank you. I was just busy writing down all those numbers, and then I realized, wait a minute, it's a webinar, it's saved, so I don't have to write down all those numbers. I really appreciate it, Jacqueline. Thank you. Also, just to kind of highlight, we also have services and supports for individuals in crises through the regional center. We have the Crisis Response Project, and what that is, that's a service that we contracted with just a little over a year ago. And CRP services is great. It's 24/7 crisis intervention for families. So if this is something that you're interested in, if you've had some difficulties or concerns, you want somebody to help out, contact your service coordinator. They can get you signed up for this. Somebody would come out and kind of, meet everybody and know. And then if there's a crisis, those folks can come out and really help to try to prevent. And if things really escalate, to help to navigate and connect with the mental health system and to get kind of crisis services in place. In addition, we have a brand new service that I'm really excited to have on board, the California START services. And this is a nationwide evidence-based practice specific for individuals with intellectual and developmental disabilities and co-occurring mental health disorders. And what this does is it helps to really mitigate crises, helps working with the individual and the family, help provide linkages and supports, really does a comprehensive assessment of needs and really helps to kind of make some of those linkages. To really tell you more about that, I'm going to hand you over to the START team.
Great, thank you, Tom. I am our AVP of Regional Center Programs at Exodus Recovery, and my team and I are responsible for the implementation of START. START is a crisis prevention and response program. We serve individuals ages 6 and up, and the people we're looking to serve are really people with behavioral health needs along with their diagnosis for the regional center that aren't being met, and that it feels like the system they're working with could use some help in working together more effectively. We tend to work with people who they might be in danger of losing their placement. They might be living at home with their family and the family is struggling. They might have issues in school or in multiple arenas. And we are fortunate enough today to have Dave O'Neill from our national team here, and he's going to talk about really kind of the specifics of START and how it works.
Great, thanks, Kali. I believe one of the things we started with was the word disparity. There's a lot of disparity among people with IDD in general, and then when you add that 33% that was kind of focused on with the IDD and mental health needs, there's numerous health disparities with getting good quality care of medical, primary care, of dental services, and then that includes this mental health services as well. If you do get into the mental health system, and Lisa did this great presentation on how you get in there, one of the things that we're concerned about is, are these the difficulties or the challenging behaviors or externalized things that you're seeing that you kind of had on that first slide, which I loved, Lisa, that first slide that just showed a bunch of kind of concerns. But those things get misdiagnosed, or they get underdiagnosed, or they're not diagnosed at all. And even when they're detected, it's hard to find treatment or people who excel in trying to make sure that, how do you take these evidence-based treatments that are out there to work with people and make it, a part of their ongoing treatment that meets their cognitive level. So START is this, it's evidence-based, which means we do a lot of testing, a lot of data gathering. We're in 15 different states, pulling data from everybody that we're encountering who has IDD and trying to find, more information, which then informs the work that we do. So that integrated sort of community prevention and intervention services are, I think, what drives START. You've heard, Tom mentioned the word crisis response. You've heard Lisa mention crisis response. We do have a crisis response component, but it's only for the people who are in START, because there is, like they said, things that are this instant response, which I know feels good and is something that's needed. That tends to be in the moment. We want to worry about, well, what happens after the crises. But we also spend a lot of time looking at what happens before the crises. So here we have these guiding principles that are up on this little list. One of it is strengths-based. People with intellectual and developmental disabilities have a lot of strengths. They have a lot of positive qualities. They have a lot of things that people like and enjoy, and strengths and interests and skills that they bring. But what do we tend to focus on? We tend to focus on the thing that this negative component, right? And it's very hard for when you're putting on top of one person that they need to change, and this person has cognitive impairment. So you need to take the things that they're good at to really start building up their skills and to really start changing the way that the system looks at these individuals. That plays into positive psychology, which is a major component of what we do. Positive psychology kind of has the premise of that the absence of illness does not mean wellness. When we promote wellness, good things happen. When conditions to promote wellness are undermined, they're not used very well, then we start seeing problems occur. So being able to understand behavior in that context, I think, and to say, what are we doing to make this person's quality of life better, this family's quality of life better, the system's, overall, experience better. Those are important, which leads that, okay, I guess that kind of covers wellness space too. Biopsychosocial model, it was a model developed by a guy named George Engel in around 1977 when he looked at everything. We actually looking at a whole person. This was decided a long time ago. It's still not quite done. Lisa had a couple of good slides that kind of talked about that. We talked about health disparity. The word behavior has come up a couple times in this presentation, and like Lisa said, you don't want to present behavioral problems because that gets attributed to the fact that the person has intellectual developmental disabilities. We are not looking at behavior. We are looking at behavioral manifestation of biopsychosocial vulnerabilities. These are the things that cause behavior. When you're uncomfortable physically, like Lisa mentioned with constipation, or if you have acid reflux, or if you stubbed your toe, or if you have a splinter, or if you itch, right? All these things will present from a medical standpoint. If you're given medications, psychiatric medications that aren't for the disorder that you should be being treated, if you're being given a medication that has side effects, how do you show those? So that's all the biological medical component. The psychological, again, is about the idea that that people with intellectual developmental disabilities do experience mental health disorders, and they actually experience them at a higher rate than people of neurotypical development. There's a lot of reasons for that around trauma, for one. And so the next little bubble there is trauma informed. People with IDD experience trauma at higher rates. There's a lot of reasons for that. Some of it is related to how they comprehend challenges, or how they're even these small traumas of how they're picked on in school and bullying that might happen, and things that kind of create a trauma environment for them. It's also, we see a lot more physical and sexual abuse. We see a lot more neglect, and those are big traumas in people's lives. So this understanding of empathy and reassurance and building rapport really goes into some of these START guiding principles around trauma-informed care. Cultural competence. I mean, this presentation is already more culturally competent than many I've ever been at, where you have the Spanish interpreter service, you have the slides. We understand there's different cultures, and people are unto themselves a culture. And what does that look like? And what is their family's culture? And what is the system of supports culture around treating them? And how have they been treated in the culture of society? So looking at all those components and how that influences someone, which is really what you're doing when you're talking about person and family centered. So those are the guiding principles that START uses. But you're now saying, what the heck does START do? That's a lot of really good ideas. Next slide. A little bit more of the direct and indirect services offer. We are, the S in START, if you saw on that first slide, was the word systemic. We are really looking at changing systems. You are not going to eliminate someone's intellectual developmental disability. If someone has fetal alcohol syndrome and the frontal lobe has not developed, there's nothing we're going to do to develop that frontal lobe. What we're going to do is we're going to build capacity within the system, have a better understanding of what that looks like. How does that manifest through mental health behaviors? How does that contribute to their communication? How does that contribute to their processing speed? How does that consider to their vocational services outcome and all these other positive strength-based stuff that they can offer, right? And you do that through this biopsychosocial assessment. So that's one of the things that we're doing. Since we are in 15 states, we're tied into the largest network of experts specifically working with people with IDD and mental health. So we have University of Massachusetts, we have the Kennedy Krieger Center, we've got, University of Florida, we have Georgetown University in Washington, D.C. We're hoping to make a link with UCLA here through this California team. So there's a lot of experts who are able to offer insight. We do outreach. It's very important. Outreach is really defined as going beyond the reach of others. So you want to reach out to, it's really important to see people in their environment. It's important to see them where the problems are happening so that you can have a better understanding of what that looks like. We have a group of different disciplines and credentials, which is what the multimodal consultation allows you to talk to psychiatrists, doctors, primary care. Tom did a really good job, honestly, of relaying a lot of what this is. He used the word linkage in consultation, which is a very big part because the last T in START is treatment, which is, and the R is resources. I don't know if we didn't spell that all out correctly, but that's really about that linkage component. You've got to have resources so that when somebody comes to you and needs something, maybe they need to get into Special Olympics because they really need some meaning in their life and they really like sports, but they haven't had the opportunity. Well, we'll have a linkage where, we know what that looks like. Oh, you don't have the money for that? Oh, Special Olympics actually has a lot of programs to help you with that. So some of this linkage and consultation that also can be done through a service coordinator level, but that tends to be for only the services that the regional center provides. There's a whole bunch of other resources out there, including mental health, and making sure that we're having this understanding that you can get regional center services and mental health services. That's an important thing, right? You can get as many services as you qualify and will benefit from. And really the benefit is for the system. So, and then there's a bunch of acronyms there that are really things that we do that enhance our understanding of the underlying cause and vulnerability. So some of those are called community education teams or cross-systems crisis plans or comprehensive service evaluation. We use a database, psycho-farm reviews. So really looking again at that whole person. And these are just different tools that we use and that you'll hear if you have an individual that's associated with START. We also do some therapeutic coaching, which is in the home or school or some other setting. Of course, with COVID, a lot of that's been virtual, but we're getting back to going into homes. And this is not a respite. This is not replacing any of the systems you already have. It's really a chance for the coach to work with this transition age youth and the family and the service provider and the respite worker to continue to build this person's skills and the capacity of the system that supports them. So this is has to be referred through your regional center. So you need to talk to your service. And they need to be somebody who we're exhibiting some sort of challenging behavior, and we don't define that. It's if you're seeing a challenge, if you're anticipating that bad things could happen, or you're really worried about things, that's prevention. I think Lisa and Tom both touched on this. The earlier, the better. Right? Much easier to start to stop something than it is to have to, take off medications from a hospital that didn't understand what they were seeing or something like that. So I think that's all for us.
Thank you. So this resources page has a lot on it. And I think always the challenge is to sort through resources. So this one was trying to kind of categorize them between developmental disabilities and regional centers, mental health, developmental disabilities and mental health, and schools developmental disabilities and mental health. And there is a handout. There are actually a couple of handouts, I guess, right? That have all that list, and you can start taking notes on it, on your own notes on top of them. One of them that I really would love to point out is the Alliance for Clients' Rights, which is in the schools, developmental disabilities and mental health category here. They have a really friendly webpage, and they have great resources for templates for letters to write to the school if you have concerns or want to appeal and stuff like that.
Tom, you want to take that question that popped in?
So accessing START services would be through your service coordinator. So they would ask the service coordinator and say that they want to be referred for START. And then the service coordinator would basically do a referral to you guys. We'd get the process going and would make sure it gets submitted and get started.
So then is the next step an appointment? What does it look like? How does it feel?
Even after the referral's made?
Uh-huh.
Yeah, after the referral's made, we'll start an intake process. They'll be probably getting a lot of releases to look at, to look at the whole picture, because we see a lot of problems with sort of, the course of treatment which got us to this point. Depending on where we're at, you probably will come out of there with at least some idea of a plan, so that families and people in services have some idea of both who to call when they need help, and that may be one of the services that were also mentioned here. That may be maybe the START line itself to do some work around some interventions. But it'll be similar to a lot of intakes that you have, of the gathering of information, trying to figure out some of those forms that we talked about around what's the perception of why this happened, what are some of the recent stressors this person has gone through, really trying to attack that biopsychosocial component from both the person's voice, as much as they're able to contribute, and then all the informants around that person. So really, it's a lot of information gathering, and then observation and outreach.
Yeah, so just very quickly, obviously the first step is to talk to the service coordinator, and then they're going to sit down. If it sounds like an appropriate case, they're probably going to talk to a couple people at the regional center, and then they're going to get consents signed, and they'll send all of that to START. And we then at START will begin setting up the intake process. So the very first meeting is just kind of a brief 15-minute meet and greet between folks at the regional center, service coordinator, maybe the program manager, some folks putting the program together, and hopefully the family and the individual or whoever they're living with, and perhaps other supports in their life. And then from there, we set up that intake process that Dave is talking about.
And I see another question: can adults get assessment for mental health? So yes, the Department of Mental Health does provide mental health services for adults, and that number that Lisa went over, the 800 number, the access number, is the same number that you would call to request mental health services for adults. And some of those TAPE providers also provide services for adults, so you can go through some of those too. But there's also adult navigators. If you're having any trouble, you can always contact me and I can direct you to the right person.
Also, in mental health, early intervention is not about 0 to 3. It's actually the early intervention of the mental health challenge, which is, typically between the ages of 14 and 24. So very much assessment is almost, for us, we're used to having young adults or adults come to us for the first time.
I really want to thank the panelists. Thank you, everybody. Lisa, thanks for taking the bulk of this. Thanks for the START program. This is going to be available. If you know anybody that wants to see this, wasn't able, we're going to have this on our website, on our YouTube channel, so people can access this. And also, if there's any other questions, you can reach out to me directly. And there we have some webs. You can see our email addresses. You can see my email, tomk@westsiderc. And thank you again. Thanks, everybody. Thanks, our panelists, and have a great evening and stay safe.
Thank you very much.
Thank you.
Thank you. Bye.